By now, we have this next session. It will be by Dr. Sharif Migawer. He will talk about ulcerative colitis, a growing disease with unmet needs. Please start.
Okay, thank you for this kind invitation, and I would congratulate you all for this event and for the launch of this society, which really I think it's a breakthrough, and we are waiting for a better future to take care of our patients. Thank you, Professor Ibrahim Mustafa, for the invitation, Professor Izzat and Professor Hussein. Also, I would like to thank Al-Hikma Pharmaceuticals for the invitation and all the organizing committee who made a lot of effort in order to make this meeting a very successful one. Dear audiences and dear chairpersons, Professor Abdullah, Professor Abdel Fattah, and Professor Nawal, thank you so much for the invitation also. And in the coming few minutes, I'll just continue what Professor Khalid Hamdi has started, the ulcerative colitis, a growing disease with a real unmet needs. Previously, we were really relying upon agriculture in our country, and we had our food, most of it homemade from plant origin. And as accordingly, you can see this very low prevalence in our country of ulcerative colitis. And as you heard from Professor Al-Madi, while modernization started and shifting to central Cairo, we started to have a lot of junk food, less exercise, and it ended up by what Ashwin predicted, that it's urbanization, industrialization, and adoption of a Western lifestyle, which made this disease emerge and flourish among our society. We know that the burden is increasing, and the bad part of the news is by the year 2025, the incidence is much, much higher than the projected statistical value. This global rise is really a burden for the healthcare system in order to satisfy all the patients and community needs. From Egypt, we have very few studies, and really, we really need a lot of more studies in order to have our own statistical evidence and in order to really have a lot of epidemiological data which help a lot. And as you heard from Professor Mahdi, a lot of these are very small studies results, and we have also just expert experience and anecdotal results, but they are far, far away from being that perfect. And this study from Zegazis has showing a prevalence of 11.2% with a predominance of ulcerative colitis. Another one from Cairo shows a very small number of patients, but at least it shows the progression of number of cases, of course, with the predominance of ulcerative colitis. So we know at the end of the day that we have an increased number of patients and we have a growing wave of patients. We have to increase our awareness, we know this. We have to improve our facilities, sure. But at the end, we have to reconcile our management protocols. And this is what this Pan-Arab Society is intended to do. Are we really mastering the management of IBD? Of course, we know a lot of IBD. All of us know that the main goals are to decrease symptoms, to keep our patient as much as we can steroid-free. We need to reach mucosal or even pathological healing. We need to patients to be free of cancer. And of course, no surgery or surgery in the proper time. Of course, I know there are surgeons attending. We know the role of surgery, but as much as we can, we would like it to be in the proper place. And at the end, we want the patient to live a very good quality of life. We also learned from Colin Pell in the late 90s that it's very important to have the three pillars of managing IBD. Early intervention is important. Treat to target policy is the best, and tightly control your patient and consider always to communicate with your patient. These are the three pillars which may change the course of IBD and give us the best results in patient care. Treating to target, of course, whatever the target is, clinical, pathological, endoscopic. At the end of the day, we want to avoid inflammation and avoid this long-term damage to the intestine. And the idea is define the target, reevaluate, and then consider to change your treatment accordingly to reach the best efficacy and results. And frequently we find this story. The patient not satisfied, there is something which is missing. And when they studied why are most of our patients not satisfied, they're not satisfied because they cannot reach the goal which they predict. And the most important reason that they are fearing medication. And the most important drugs they are fearing from is immune modulators and biologics. And by number three is the steroids. But considering that treatment is very important to give the patients his satisfaction, we have to increase our arsenals of medicines in order to reach proper management with least doses of dust and the least side effects. This group of expert met, and I just want to mind you, included, of course, very well known, such as Silvio, such as Loren and Stephen, a big group of big names in the field of IBD, and they found that there is a big bunch of unmet needs, including delayed diagnosis and treatment, the discordance between the patient-reported outcome and mucosal healing, and the lacking of monitoring systems, which should be simple, easy, non-costly. The challenging of differential diagnosis is very important. The patient adherence is very important, and non-satisfactory response to the existing treatment and the use of biologics should be really optimized. And we, at the end, they recommended the need of new treatments. And of course, Professor Khalid gave highlight on many points of these. And the evidence was this report from Las Vegas telling us that there is a delay at least 1 or 2 years in diagnosing IBD, which I really realize in our country could be much more longer, and patients persist on treatments non-specific to the IBD for longer times, and for Crohn's disease specifically, they may stay for years before the diagnosis. The discordance between the patient's reported outcome and mucosal inflammation is really very important to know. And the only symptom which really was correlated with mucosal healing was rectal bleeding. On the other hand, number of stool frequency was not correlated with mucosal healing. So we know that we need tools for early diagnosis and tools for monitoring. We need to have an early effective treatment. We need to reach the point of precision medicine, which relies upon genomics and all omics we know about. The need for less expensive and safe, effective treatment is really a demand. Simple tool to monitor, again, I would mention for the second time, is very important. And the best thing is to reach the point of primary and secondary prevention of illness. It's a journey we have to ride to improve the outcome. All through the journey, we know that we have goals which may differ a little bit from patient goals, but at the end of the day, the target is the same. Symptom-free, mucosal healing, deep healing and pathological healing, good quality of life, no cancer, and of course, surgery in the proper time. Early effective therapy was found by this review article to be the most important. They studied why did the incidence prevalence increasing. It's related, of course, to genomics, change in the environment, to microbiomes, as many of my colleagues have been illustrating in their very elegant talks. Of course, this also could be due to the increase in the life expectancy, but at the end of the day, there is an increased cost of treatment of IBD. And if we will really work hard to decrease the incidence and prevalence and the cost, we have to start by early, effective, available treatment. Of course, our end goal is to personalize our therapy and to prevent the disease, and at the end of the day, decrease the costs and, of course, the economic burden of this disease. Simple, accurate methods of monitoring, and from this very elegant study, they have been proving that using the patient reported outcome using the bleeding per rectum as well as the stool frequency, adding to it calprotectin was found to be a very simple and a very accurate tool in order to monitor our patient's treatment. And we can tell without even endoscopy how is our patient moving on. Optimization of medical therapy is very important. We have a bunch of treatment to reduce the induction. We have a big other group, and you hear this from all our colleagues talking about many medications already available and others already in the pipeline. And we are gradually increasing the arsenal of our management protocols and management medications. We know a lot about systemic steroids. We know the benefits, but there are limitations. They are very good drugs, reaching 70% response in the first course of therapy. We know that they could be used after 5-amino salicylic acid failure. They are very potent in induction of remission. They could be given orally or IV, and IV route, especially in the severe forms of inflammatory bowel. But there are many limitations. Most important is, of course, the side effects which develop early after they start the course. The mood changes, the hypertension, the fluid retention, and on the long term, the skin thinning and the poor healing, the cataract, diabetes, all of these side effects the patients hate to see when we use the systemic antibiotics. Biologics are there, and every day we have new biologics. They have a good benefit. Of course, they are effective. Of course, they improve the quality of life, and they improve the rate of mucosal healing, and they have succeeded in reducing the rate of surgery. But of course, there are many, many limitations. First of all, we face the immunogenicity, which may result in primary and secondary failure in some of these biologics. And the pharmacoeconomics, they are expensive. They have a risk of infection. And of course, many of them have a slow onset of action, which really makes them only for maintenance and not for induction. Not all, but at least most. Immune modulators have a lot of benefits. They are effective when given with steroids. We can succeed in reducing the dose of steroid. They improve the efficacy of other medication, but they have their limits. Nothing is without price. The suboptimal safety profile, increased infection, of course, myeloproliferative disorders, which may develop on the long term, these adverse effects may be a reason the patient may withdraw or stop treatment at any time. So what should we do to overcome patients' concern? First of all, we have a lot of conventional therapies, which we have to know their real effect. And we have to optimize them. And we have to know that, for example, not all of them are the same. Suppositories, for example, work better in cases of proctitis. Enemas are the best in cases of sigmoiditis. We can increase the duration of our treatments. If after 8 weeks you do not get a response, extend to 16 weeks. And of course, you can maximize the dose. You can combine oral with rectal or with enemas. So please do not consider a drug to fail except after optimizing everything. And always remember that you have to reach a dose not less than 2 grams for induction and maintenance to say that you have done the job properly. This is, of course, for the 5-amino salicylic acid. Combination works very good if you combine oral with suppositories, oral with enemas if you have sigmoiditis in your patient. This will really improve the outcome, and you can see after 8 weeks, almost 85% of your percent may show a good response to therapy. Be sure that you are targeting the proper part by the proper drug, by the proper route of administration. Enemas, and this study showed that 30 millimeters of an enema will really target the sigmoid with a median delivery to the different areas with the maximum area affected would be the sigmoid bone. Only 30 milli enema will be effective in sigmoiditis. Be sure it will not affect the rectum, it will be to the sigmoid. So know the route you are administering and the part which is affected. Extending the duration, of course, is very effective. And of course, adherence of the patient should be thought of at every time, since the WHO considered 30 to 50% of medicines prescribed for chronic illness. In those cases, those patients are not adherent to the treatment and they are not compliant. And the main reason for this is they are fearing the side effects of the medicine. So this is a point we have to consider. Give the patient the drug with minimal side effect, talk a lot about side effects, how to prevent and reach the lowest possible dose with these side effects. Because most of the time of non-adherence, it is intentional by the patient himself. And you can always see that only 40% of your patients who are in remission are adherent to treatment. This is the reason why most of medications fail treatment. Of course, if you give the patient a once daily dose, you will find a bigger number of your patient adherent to treatment, reaching 100% in 3 months and 75% after 6 months. So consider always giving less frequent tablets and less frequent medication. Steroids, I told you they are effective, but the nightmare is really very, very much distressing to our patient. Patient acceptance is improved when we use local forms of steroids. Adherence is better with the new forms of therapy. And here comes the budesonide MMX oral and multimatrix oral steroid, which showed an excellent efficacy with the least systemic effect due to the first pass metabolism in the liver. This unique technique really targets entirely the colon from the cecum till the rectum. And as you can see from the study by Sandberg, that there was a remission in at least 17.9% of cases after 8 weeks. What's meant by this remission? It's not only symptomatic, it's endoscopic, and it was also astonishingly to be histological improvement in 17% of patients. A drug which is steroid with the high efficacy of steroid, but the least side effect, which can be used in induction of therapy in our patients. By this, dear audiences, dear chairpersons, I would like to conclude that we have a rising burden of ulcerative colitis in our country and in the Arab area, of course. Early diagnosis is necessary, but needs more awareness. Success relies upon all players, from the patient side, physician side. In Egypt, IBD is a disease of high economic burden. Unmet needs should be managed with respect to financial issues. By this, thank you all, and if there's any question, I'll be happy to answer.